Our last speaker, I'm not too sure where he's hiding himself, is Dr. Brennan Mackenzie. If he'd like to come up to the podium, please. Brennan joins us from a transatlantic trip from California, is that correct? That's right. And Brennan is a general practitioner in California, having qualified from Penn State or Pennsylvania for veterinary medicine. Okay. And he's quite versed he writes and speaks regularly on the subject of evidence-based veterinary medicine and complementary and alternative medicine. And we're looking forward to your words of wisdom, sir. Thank you very much.
I will try to confine myself to the podium. I'm one of those speakers that likes to move around and gesticulate, so this is a little bit of a challenge for me. I really am excited for the opportunity to come here for a lot of different reasons. One is that I'm putting a lot of faces to virtual identities. Oh, thank you.
You're very welcome.
Thank you. And obviously the folks at the Center for Evidence-Based Veterinary Medicine are doing a lot of exciting things, and it's nice to meet them and talk to them and share ideas, and also to get the perspective from the UK. I think the administrative and regulatory structures, and to some extent the practice models and the economic models are a little different here, and so that's useful for me to learn from. I'm not sure if my perspective is truly global, but it may be a little bit different. In one respect, I'll tell you a little about myself. This works, I can use that. Okay. I graduated from the University of Pennsylvania in 2001, so I've been in practice a little over 10 years, and I am truly a general practitioner. I don't have any special academic qualifications, and I'm not a researcher, though I am interested in trying to get some research going in my practice. I'm not a faculty member, though I do have an arrangement with one of the veterinary schools there to try to bring students in, and we haven't had any yet, but we're interested in teaching in our practice. So I work at a really nice practice. We have about 26 veterinarians, so we're quite large. We have a very large and affluent client base, which allows us to do a lot of interesting and advanced sorts of medicine. And so certainly evidence-based medicine is really important for us because we're sort of in an intermediate niche between first opinion and referral practice. My interest in evidence-based medicine came about as a general practitioner from trying to answer questions that my clients asked me and to make better clinical decisions. And so I very much see it as a useful and pragmatic tool for practitioners. There are other elements to how we build it that relate to the university experience, the research experience, but my perspective is going to be that as a general practitioner. I wear a couple of different hats. Part of the way that I became involved in evidence-based medicine was through getting a lot of questions about what are often called complementary and alternative therapies. I live in an area where those things are very popular. They're widely used by people for themselves, and so they would come to me and ask me questions about the use of those sorts of approaches for their pets. And there's not this is not something we talk a lot about in veterinary school or that we're trained in, and so I had to go out and try to find information and answers. And doing all of that work, I want to make that available to other people, so I started writing pamphlets and handouts for clients, and that led to this blog, which led me into the whole question of how we decide what is true and what's not true, what's effective and what's ineffective. Really interesting epistemological and philosophical sets of questions, which I think ultimately do relate back to what we actually do every day in practice. So this is a site where I do a lot of writing, which mostly focuses on this area, but bleeds over into the broader question of evidence-based medicine and how it affects practice. The hat that I'm wearing today is as president of the Evidence-Based Veterinary Medicine Association. And can I just, since I don't have the fancy poll set up, can I get a show of hands? How many people have ever heard of the Evidence-Based Veterinary Medicine Association? Nice. That's much better than I was expecting. Great. This is a group that was founded mostly by academics in 2006. It came out of a series of meetings much like this one held starting in 2004 and going forward. And it's a group that I very much see as hopefully a crossroads or a means for bringing people together to talk about evidence-based medicine in the veterinary domain. We're not affiliated with an institution. We don't have a large funding base, so I don't think we're an organization that's going to be generating systematic reviews or practice guidelines or a lot of the meat of evidence-based medicine as it's applied. But I think we have a brain trust, if you will. We have people who are passionate about this idea and who have particular areas of expertise. We have a large contingent of librarians. We have a lot of researchers. I've, somehow ended up in the big chair as the general practitioner, and so I'm putting a lot of our focus and energy on how to make evidence-based medicine useful and interesting to practitioners. And this is a group that is in some sense global, not as global as I'd like it to be, and hopefully we're working on that. It was largely put together, as I said, originally by veterinarians in North America, and most of our members are still there. We have one lucky member in a nice, warm, sunny climate in the Caribbean, and we have quite a few members. Obviously, the folks at Nottingham, many of the folks at the Center for Evidence-Based Veterinary Medicine are also EBVMA members, and quite a few researchers and academics throughout Europe. You'll notice there are a few small gaps on this map where we don't have little buttons. I know that there's a lot of evidence-based veterinary medicine being practiced, a lot of relevant research and activity going on in other places. And for the EBVMA to be useful, we need to bring in people from all of those places and try to have conversations. There was a recent systematic review, which I'll refer to later, on nutraceuticals for osteoarthritis in dogs. And it was done by an international group largely based in the Netherlands, and I wrote a comment for JVM, a letter to the editor about that. And that led to a really great back and forth discussion about how we develop tools to do better systematic reviews in veterinary medicine. What do we need in order to all be speaking the same language and using the same terms? And I think that kind of conversation can only make this more effective. We are largely a virtual organization. Sorry, I think my little animation is slowing everything down. We exist primarily through the web. We have probably about 120 members at any given time, and we do have some face-to-face meetings, but most of our conversations are through the internet. So the website is largely where we put things, and what I'm trying to do is build that into a resource that anybody anywhere can use, that provides a clearinghouse for things that help us to practice in an evidence-based way. Susan Whittaker is someone who's put together a brilliant bibliography of evidence-based veterinary medicine, and that is a great place to start if you're looking for literature on what this is and how to use it. We have a fellow named Stuart Turner, who's a vet, and he's also a bioinformaticist. He works for our national institutes of health mostly, and he does a lot of neat things with computers that the rest of us don't understand. One of those is this little tool which automatically pulls up the articles published in particular journals each issue as it comes out. And what I love about this is the little map, which then indicates where this research was done and published, and this again shows sort of the global nature of this process, so you can see where things are being done. This is a digital age, and so particularly as a relatively underfunded organization, we do a lot of our communication and outreach through digital media. Are people familiar at all with the Veterinary Information Network? I don't know how much use of this there is in Europe. Does anybody belong to VIN or participate in VIN at all? A few. I know there are other organizations like this. This is the predominant one in the United States, and so we have a folder there where we make announcements and we have conversations about this. There was a recent provocative thread entitled "A Cancer at the Core of Evidence-Based Veterinary Medicine," where we talked about the issue of the reliability of the published evidence and what that means for what we're talking. So we are trying to do that. I wouldn't say we're young, but we're trying to keep up with the social media, because I think that's the way particularly a lot of younger veterinarians are going to communicate, and so we have presences on a lot of those as well. We're obviously trying to partner with as many other organizations involved in evidence-based medicine as we can. Banfield, as you know, is a commercial practice, very large practice in the United States. We are currently working on a critically appraised topic competition for students as a way of both raising awareness of evidence-based medicine and teaching students these techniques. A critically appraised topic is a very sort of quick and reasonably dirty form of review of the evidence, but it's very practical, it's a very narrow, focused question. And what we're doing is asking students to make these, and many students are already, there are some faculty who are requiring this as part of training, to write these cats and then submit them as part of this competition, and a small number of them will get to be published. They'll get a little cash prize, they'll get some recognition. All of them, if they meet sort of a set of basic quality criteria, will be published on our website. So then this also is cross-purposed as a resource for veterinarians, where you can go and get answers, you know, to particular clinical questions. And we're trying to build our resources that sort of way. There we go. We also offered, for the first time this year, a small grant for people who are doing research specific to evidence-based veterinary medicine, because we're trying to encourage research on things like how to design and do systematic reviews, how to teach evidence-based medicine, how to create tools for practitioners. It's only about $1,500 US. It's a relatively small bit of money, but it helps to maybe add on to other funding sources, and we're looking for ways to increase that amount. We have a lot of members who've been involved in designing reporting standards so that when the research is done and reported in the journals, we have some important quality factors included in that, and it's reported in a way that makes it more reliable and more trustworthy. We have a number of members, including Mark Holmes, who's I think is here at Cambridge, working on trying to look at the possibility of establishing a veterinary arm to the Cochrane collaboration, and there's a lot of really good debate about how that would work and whether that would be useful, but that's something that we're looking into. And we do have one actual physical meeting where people get together and have conversations and lectures. We do it every 2 years. We try to pair it with a large CE meeting in the United States. ACVIM was the one we did this year, and that's probably what we'll do the next time. 2014 is our next one. So a lot of different activities, mostly centered around stimulating and facilitating discussion and talk between people. Because I think meetings like this are how we're going to make evidence-based medicine work. We need input from all different domains within veterinary medicine. I probably don't need to spend a lot of time on why we need evidence-based medicine in this group. We've got a nice self-selected group, though I was pleasantly surprised to see, you know, a good quarter of you still had some doubts about whether this was a practical tool for practitioners, and that's something that I obviously believe quite strongly. So I'll talk a little bit about one way of looking at why we need this. We use information to make clinical decisions. So what is the information that we use? A prominent piece of the information we use is our clinical experience, or what I prefer to call uncontrolled individual observations, to distinguish it from more systematic research. And I agree with everyone who has said so far that individual clinician experience is indispensable. Medicine is an art as well as a science. I think, however, particularly as we go on in practice and as we get older, we become perhaps a little too attached to our opinions and our experiences. And there's very good reason to believe that they are biased and flawed in very specific and predictable ways. There's a rich literature in cognitive psychology that shows us how we make mistakes and why we're wrong and don't know we're wrong an awful large percentage of the time. Some in the human field have posited that the 3 most dangerous words in medicine are, wait for it, in my experience, right? The reason these words are dangerous are not because it isn't true, experience is useful, they're because they become an excuse for not challenging our own beliefs and preconceptions and practices and going to the research. The hardest thing to do is to give up a belief that is self-evidently true based on numbers of cases that you've seen before. And yet that's what evidence-based medicine requires of us. So what other sorts of information do we use? We use tradition, right? What we've done is what we tend to do when in doubt. And we use the opinion of august experts who we trust and respect, our mentors, people that we know are very smart and very well educated. Galen was very smart and well educated, and we followed his advice for a really long time, and he was wrong about an awful lot of things. So the fact that evidence-based medicine is about questioning established wisdom, I think, is really important. There's pretty good reason to believe that that's not a reliable strategy in the long term. We've talked about pathophysiology and extrapolating from that to other things. Necessary but not sufficient. I absolutely agree. I do it all day long, particularly when there is a lack of good controlled evidence to tell me what to do. But I also know that small bits of information I don't have can make this a really dangerous strategy. So what information should we use? I think ideally scientific research evidence should be the core of our foundation for clinical decision making. We have to integrate that with many other things, and those definitions, the classic definitions of evidence-based medicine, all talk about this. We need to integrate that evidence with our experience because that's how we apply it to individual patients. And knowing when a particular patient does or does not fit the criteria that we use for the evidence was generated by, it requires our individual experience. We also have to think about the practical aspects of things. Do we have the resources or the expertise to implement a particular therapy or strategy? What do our clients care about? You know, the perfect strategy or the perfect therapy, if our clients don't want it, is not the perfect therapy anymore. So we have to include all of these other factors. But I think if we start with the core of controlled scientific research as our foundation, then at least the decisions we make are informed by the most reliable knowledge that we can have. And we'll just wait. This is what I get for being fancy. So why do we need evidence-based medicine? Because I think it provides us with better information than the other sources of information we have. I think controlled research ultimately is more reliable than these other information sources. Why does that matter? Well, we've already touched on this. The goal is better outcomes, right? We want our patients to get better care and to do better. And I think it is reasonable to believe, and we'll talk a little bit in a minute about whether we've proven it, that better information leads to better outcomes, right? If you're wrong about what the effect of your intervention is or what the diagnosis is, then your outcome is likely to be affected by that in a negative way. I think there's also an issue which maybe we haven't touched on, which is the question of informed consent. Our clients make decisions for their animals and tell us what we can and cannot do. And they can only make those decisions in a meaningful way if they have accurate information. If we are explicit with them about the limitations of what we know and what we don't know, about the confidence that we have and they should have in our recommendations. If we aren't, then I don't think that we're giving them the opportunity to exercise their autonomy and make clearly informed decisions. This is a big question in human medicine because patients are now understood to have the ultimate authority to make decisions about their own health care, for better or worse. You know, we all know that we can guide our clients in the direction we want them to go often, but I think we also have at least some belief in the ethical principle that they ultimately have the authority to make decisions, and we need to inform those decisions. This is a little graph which I won't place any money on the accuracy of the specific numbers here, but it illustrates a pattern which I think is relatively clear in the history of human health. This purports to be the average life expectancy of human beings over about the last 10,000 years. Now, you know, again, how much of this evidence is reliable? Probably not very much. But I think that if you look at what we do know about the history of human health, about key markers of well-being, things like life expectancy, infant mortality, you know, those sorts of things, there's no question that for a very long time we hit a ceiling where we were about as healthy as we were going to get, and we weren't able to change that. When did we first begin trying to improve our health or protect our health? Far back as we can go, right? There's evidence that people have been using, you know, medicinal herbs and practicing various sorts of rituals and doing all sorts of things to try to figure out what is necessary for health and what helps us to treat disease. And we didn't have much of an impact. And then somewhere along the line, we developed this thing we call science, and all evidence-based medicine really is the formal systematic application of the scientific method to clinical practice. And something changed. We figured out how to manipulate our world in ways that had an unprecedented impact on health and well-being. And I think this pattern is an important one to keep in mind because we exist in this tiny little bit at the top. And without a historical perspective, it's very easy to get caught up in all the details about how, you know, randomized clinical trials are often flawed and the conclusions are often untrustworthy, and to begin to forget how powerful the scientific method is in terms of giving us information that is more reliable and allows us to make more accurate and better decisions. We'll wait. Okay. Another area that I think evidence-based medicine is useful for, and this has been alluded to as well for the practitioner, is in information management. There's a tremendous amount of information available to us now, and finding out how to use that in an effective and efficient way is part of what evidence-based medicine can do for us. It's not just about guiding our practice, it's about using the information that we have in the best way possible. That begins with figuring out what it is we need to know. Learning to ask answerable, focused clinical questions makes the information that is available to us much more useful. And then, of course, the question of how do we find the information. If you don't know how to use the literature, if you don't know how to access it, then it's not going to be very useful to you. And specifically, and this is one that I think the folks who are in the academic and library sciences can be really useful to us, how do you make that information practically, pragmatically useful? Can it be summarized for you? I read an awful lot of primary literature because I'm kind of a nerd and I like that sort of thing. But I have my patients coming in every half an hour on the half hour, and there's a limited time for that. And if that information is processed and digested for me, that's really helpful. And critical appraisal. I'm happy to go through an article and say why I think the conclusion is nonsense. But if that's already done for me, particularly in a form like a systematic review or like a practice guideline where I can rely on the conclusions because someone has done this work in a transparent and systematic way, that makes that information more usable. So evidence-based medicine is a strategy for information management as well as information generation. This is an idea that I stole from the Handbook for Evidence-Based Veterinary Medicine, Cockcroft and Holmes. I think there are a couple of different models for how we manage the information that we need for our practice. The just-in-case model is what I was certainly trained in, and probably most of us were trained in. You stuff as many apparently unconnected facts into your brain as you possibly can, and you keep them all in there, waiting for the moment that you need one of them. Something walks into your practice and you look at it, and all those facts are there waiting for you to organize them and put them into play. And I think most of us recognize that's not a very efficient strategy for information management, particularly as the amount of good, reliable research information grows. We just don't have the capacity to do that effectively. So what has been proposed instead is what's called just-in-time information management. That means that you figure out what it is you need to know in a systematic and organized way, and there are strategies for helping you do that, and then you go and get that information and you apply it in real time. And in human medicine, there are lots of information technology tools to support this. My last time I went in for my general consult, my doctor, walked over to her little computer and typed in a diagnostic code and got the latest systematic review on what therapies and interventions would be useful for me right then and there. There are ways to support veterinarians in doing this. We're a long way from being there, but I think that this is a model that if we accept it, we can develop the right tools to be useful for. Okay. Again, better patient care. The issue here is, does evidence-based medicine make your patient outcomes better? And I agree that that is not a case that I can say has been proven in a conclusive way. I do think that other than the basic rationale and the historical perspective, there is some evidence to say that this is true. This is an example of one way that we can approach asking and answering this question. This is a study looking at the implementation of evidence-based practice guidelines in human hospitals. And they followed patients before and after the implementation of these guidelines and did find a general trend that outcomes were better in places that had implemented evidence-based practices than in places that had not, or after these implementation than before. So I think this is one little piece of information that helps us to say, I do think there's some value to this. And interestingly, the conclusion here also says that the outcomes improved for the people working in the organizations. One thing that I think we don't emphasize enough is that good evidence-based practice guidelines and practices can make your life a lot easier. And I'll talk about a great example of that in a little while. It's not just about making you work harder and do more work. It's actually about making your work more efficient and easier. If we don't make the tools to make that possible, and if we don't convince practitioners of that, they're going to ignore this. Better information management, that's the other aspect that I'm talking about for evidence-based medicine, also improves outcomes. This is a study looking at whether information technologies, including some of those decision support tools, things that allow you to access the relevant information in real time as you work with a patient, also do seem to improve outcomes. Now, I've had very frustrating encounters with my hospital electronic medical record systems, and it's clear that these things are not flawless or perfect, but there is some evidence that they improve the quality of care that we provide, and that's one thing that I think evidence-based medicine offers. So then the question comes up, if this is so great, why aren't we already doing it? If we aren't, and I don't think we are, but why aren't we already doing it, or what is it that's getting in our way? As a general practitioner, and I think this is a self-selected group, so that probably is less true in this room, I feel like one of the biggest challenges is people just don't see the need for this. Where people are comfortable with the information management and clinical decision-making strategies they already use. And as I said, I do a lot of writing and speaking on the subject of alternative medicine. This is an example from that just because that's an area I'm familiar with. I don't think this is by any means exclusive to alternative medicine. I think this is a problem that runs throughout our profession. But in response to a series of articles and discussions about the evidence base for homeopathy and chiropractic, this practitioner said essentially, I know it works, I do it, I see it. I don't need you to tell me that it works or doesn't work through systematic, organized research. And I don't think that's a really rare philosophy. I think a lot of veterinarians feel like the feedback from their patients is discrete and objective and obvious, and there may not be a need for them to change their practices. That's something I think we have to overcome. This was a study done in the Netherlands where they did some surveys and some guided interviews looking at how veterinarians make decisions in clinical practice. And the interesting tidbit for our purposes here is that the question of evidence-based medicine never came up in most of these discussions for how people made their decisions, with the exception of people occasionally saying, you know, that research isn't really relevant to what I do anyway. It doesn't help me, it's too abstract, it's too, you know, academic. There are reasons why it's not useful. I think this is still a problem. Okay. And then there are a series of myths and misconceptions. I think that what evidence-based medicine is and isn't is something that we need to clarify for general practitioners so that they will see that some of their objections may not be real objections. One that I hear all the time is, yeah, it's a great idea, but we can't really do it. I mean, we don't have enough evidence and we don't have any money to generate evidence, so, you know, let's just not waste our time. It's never going to happen. And I am often accused of saying, look, if you don't have a meta-analysis or systematic review based on huge numbers of trials, you can't do anything, right? Evidence-based medicine means stand there with your hands in your pocket if you don't have perfect evidence. And that absolutely is not what it means. A great deal of the decision-making that I do on a daily basis is not based on really good, solid research evidence because I don't have it. It isn't there. It simply means making the best of what we do have, okay? One thing that came out of that survey in the Netherlands is that evidence-based medicine is about being explicit with ourselves and our clients about the limitations on our knowledge and what we know and don't know. And some people fear that clients don't want to hear that. They want confident, definitive recommendations. I think this goes back to a subject that Jeff is very familiar with, which is communication. I have had to restructure how I communicate with my clients so that I can be honest with them about the limitations and the evidence supporting what I recommend, and at the same time retain their trust and their confidence. And I think it is possible to do that. I think there's some surveys of people in terms of their interactions with their physicians that suggest that while people do care a great deal about their doctor's demeanor and confidence, they also care about their doctor being very familiar and conversant with the most recent evidence and being honest and direct with them about what we know and what we don't know. And I think our clients can appreciate that honesty, and that helps them to make truly informed decisions. One thing that Sally mentioned, the question of how applicable is evidence to individual patients. Studies are done on populations, and a lot of people say, you know, that just tells me the average. The average doesn't ever apply to any particular patient, so how am I going to use that? What I often say to people is statistics, particularly as applied to games of chance, are general rules. If I go to Las Vegas and I play, you know, craps, I don't know if I'm going to win or lose. I just know what the odds are, right? But casinos make a great deal of money by assuming that the odds really do apply. And in pragmatic, everyday decision-making, ignoring the average, ignoring the population-based data is probably not a good bet, even though sometimes it won't apply. And as I mentioned before, a lot of people feel like they already know the outcome with their patients, and if they know what the outcome is, I gave the cat with, you know, hematuria clavamox, it got better, it must have had a UTI. You know, they're comfortable with the fact that they don't need the evidence because they already know the answer. And with reference to the subject already talked about, practitioner autonomy, people will say, you know, this is just those eggheads in the university telling me what to do, and I'm tired of people telling me what to do. I work in the real world, I don't have unlimited resources, unlimited time, my clients want what they want, and evidence-based medicine is this abstract thing that's not really useful to me. Obviously, I don't believe that, and I don't work in that academic world, and I feel like it's tremendously useful and could be more useful if it were more widely accepted and we developed better tools to implement it. So I think practitioner attitudes are a significant challenge, and that's something that we need to do outreach and education on. I absolutely acknowledge that limited evidence is a huge problem for the pragmatic application of evidence-based medicine. We don't have the evidence base to do a very good job of it yet. This is a question that I was interested in when I first started looking at this stuff. You know, is glucosamine useful for the treatment of osteoarthritis? I was selling it for years, and everybody I know was, and then, you know, the question came up for me, does it work? So in human medicine, the Cochrane collaboration, which is sort of the preeminent agency doing this sort of thing, did a review, and they looked at 25 studies with about 5,000 patients. Some of those studies lasted 2 years, and they came to a conclusion. I said, great, I want to do this for veterinary medicine. I'm not smart enough to do a systematic review, but I can do something quick and dirty, and it was a feature for a while that the EBVMA sponsored in the Journal of the AVMA called What's the Evidence, which was more like a critically appraised topic. So I said, I'm going to go do that. I found 2 randomized controlled trials with about 110 dogs, and then the longest of them was 2 months, right? So how confident could I be in the conclusions based on the evidence? Not very confident. Okay. So this is absolutely a real challenge, and we all acknowledge it, and I'm going to keep, you know, handing that back over to the folks at the Center for Evidence-Based Medicine and those of you in academia. You know, we do need better and more evidence in order to do this. Now, I'm also, because I need to know more to speak authoritatively or at least intelligently about this stuff, I'm doing a master's degree in epidemiology through the London School of Hygiene and Tropical Medicine. I'm doing it as a distance learning thing because my wife said I wasn't allowed to go back to school. I have to keep making a living. However, in doing that, I'm going to do a research project in my practice. I'm going to look at the question of whether dogs with diarrhea benefit from being given metronidazole. And I don't know how common that is here, but that's given out like candy to every dog with diarrhea in the United States, you know, pretty much automatically, largely on the basis of the fact that clients want something to do. And I don't think there's any research to tell us whether it works or not. It's certainly not going to be an attractive study. I have little sheets showing different kinds of diarrhea so my clients can score the poo. You know, it's not the kind of thing that needs to be done in academia. So I do think there is some room for the general practitioner to contribute to the evidence base. But a lot of that's going to have to be done above that level. Access to the evidence. This one drives me crazy. Once I decided I really wanted to use this method, I found that if you're not at a university, it's really hard to get to the literature. You know, there are paywalls set up for a lot of journals, and there are some workarounds, but, you know, people in the room will tell you that I write to people I know at universities and say, could you copy this paper for me sometimes? Because it's really hard to get to. It's not useful to us if it's not accessible. And this is just a little survey, which I've also heard referred to as a rant, and I think it's a great paper essentially saying we got a long way to go before we can make the information that is available accessible and useful to people. The information infrastructure that we need to do this isn't there yet. But if we accept that we want and need to, we can build it. Okay. And then resources. There's no question that we have limitations in resources. And this is a area in which organizations like the Trust can be really helpful in resources. And, you know, what do we mean by that? Well, there we go. We need money, right, and time. I work with a lot of academics in the EBVMA who are really interested and really passionate about evidence-based medicine, and then I ask them to join a committee or to do something, and they say, gosh, I've got my research project and I'm teaching, and, you know, I do a lot of my writing and my research and my activities in these little windows between appointments, you know, because I've been in practice long enough that I can get my appointment done in less than the time scheduled for it most of the time, and then I can sit down and do a little bit. You know, time and money are limited factors, and this is something that, you know, we need. What do we need to do? What are these limitations on? Well, we need to generate more and better research, right? We talked about that. We need to get that research to where it needs to be so the information's available. We need to get it to people in a usable form, and then we need to use it. We need to implement it. We need to actually take that information and do something with it. And I think we need to teach it. We need to teach it certainly to students, because I'm old enough now to believe that the time for my generation is almost done. You know, we need to teach the students if we want to change the culture of veterinary medicine. But we also need to teach our clients. And I think that they need to look at how we make decisions and how we make recommendations in a slightly different way. And so those are things that we need resources to do. All of that said, I want to give you just a few examples of where I think this is being done, and being done in a way that I have found useful and that I think other people will find useful as well. This is a systematic review that I referred to earlier, looking at the question of, are nutraceuticals useful for osteoarthritis? And this is a great paper, and it also, as I mentioned, generated a really good discussion about how we do these reviews. The authors were frustrated by the lack of consistent measures for outcome. How do we know whether a dog's arthritis pain is less or not? And so, there's a long way to go, but this was very useful for me to say to my clients, well, here's what we know so far about this product, and do you want to spend your money on it? And this was an international collaboration, and that's partly why I'm here, and what I think the EBVMA is useful for is bringing people with interests and expertise together to do this. Another area which I think someone's going to talk about a little bit later is the Task Force on Canine Atopic Dermatitis puts out clinical practice guidelines and reviews the evidence for particular therapies. This is a tremendously common presentation at my practice, and a very frustrating one because we don't have really definitive perfect therapies for it. So we have to manage it with a wide variety of therapies that we know very little about. So these guidelines are very useful to me, and they're generated in a way that I can appreciate and evaluate, and this is something that's happening already. This is my current favorite example, and is anyone familiar with the Recover Initiative and the new guidelines for veterinary CPR? A few people. This is something that I want to hold up as the paradigm, as the model for how we can do really good evidence-based medicine. Recover, the reassessment campaign on veterinary resuscitation, this illustrates one of the key factors, which is if you're going to do a good evidence-based medicine project, you need a cool acronym, right? And this, I'm sure a lot of thought was put into that. This was done by Dr. Daniel Fletcher and Manuel Bowler at a couple of universities in the United States. The Dr. Bowler did train in Switzerland, so there's, again, that global perspective. And the goal was essentially to generate evidence-based and also consensus-acceptable guidelines for veterinary CPR, okay? In my practice, because we're large, because we do a lot of medicine on very sick animals, and we have a high patient flow, this is a fairly common event. And so this was to try to give us some guidelines. Why do we need guidelines? This is some data that I borrowed from Dr. Fletcher, who has gotten this from a couple of different papers. And it says something that I think most of us probably already know, right? Which is that an animal experiences a cardiac arrest, and then we do whatever we do for CPR, and most of them were done because we don't ever get any response to that, but about 35 or 40% of them will get a return of spontaneous circulation, which we would love to think is the endpoint of CPR, but it's not really. The endpoint, the outcome that we're interested in, is we send them home. And of that 35 or 45% that have a return to circulation, most of those never go home. Maybe 6 or 7% of those survive to discharge. And the second little box up there is some additional data which specifically looks at the cause, right? Case selection is important here. If you have a 14-year-old golden retriever with lymphoma, your expectations for survival to discharge are going to be different than if you have a 2-year-old dog that's in for castration. And so clearly we do a little bit better with different cases. But overall our success rate is pretty abysmal. So this is some data looking at the effectiveness of cardiopulmonary resuscitation in a tertiary care human hospital. So these are the sickest of the sick, right? And this specifically looks at the intermediate outcome, right, return of spontaneous circulation, as well as survival to discharge, before and after the implementation of these advanced cardiac life support guidelines. So again, this is one of those pieces of evidence we use to decide if what we're doing actually makes any difference. And essentially what they found is that prior to training people on how to do this in this evidence-based way, you got about 18% of these patients to return to circulation, and about 23% of those went home. Pretty poor outcome. The outcomes were considerably better. 28% return to spontaneous circulation and 69% survival to discharge after the implementation of these guidelines. So this is essentially the same patient population, but with much better outcomes once we systematized certain practices that were based on, direct appraisal of the evidence. This, I think, is a good reason to say maybe we should try this in veterinary medicine. So these guidelines were modeled on ILCOR, which is the organization that sets ACLS and CPR guidelines for physicians. And I think the important point here is that we don't have to reinvent the wheel. Evidence-based medicine has been done and implemented extensively in human medicine, and there's a lot that we can borrow and adapt from human medicine. And so one of the ways that they made this a pragmatic and efficient process is by copying or stealing a lot of the process that already existed. They started by focusing on very clear, specific clinical questions. And there's a system in evidence-based medicine called PICO, where you ask a question that you want to answer in terms of what patient population is it that you're interested in, what is the specific intervention, what do you want to do, what are you comparing that to, and what outcome are you measuring. And so, for example, they generated a long list of questions like, you know, in dogs who experience a cardiac arrest in the hospital, does vasopressin compared to epinephrine as a first-line drug have an effect on survival to discharge? Things like that. Very specific clinical questions. If you say, does CPR work or not work, that's not a question you can answer in an evidence-based way, right? So they started with good questions. And then they identified the research that was relevant to these specific questions and went about engaging in this critical appraisal process we've talked about. This is just an example of their particular series of levels of evidence. It's a modification of that pyramid that we're all used to looking at you know, case reports and small levels of evidence at one end, randomized clinical trials on the other. Okay? And then they went farther than that and they tried to look at the quality of the evidence. So randomized clinical trials can be great and high quality, or they can be poorly done and very low quality, and you have to take that into account when evaluating the reliability of that evidence. So they came up with a very systematic way of doing this. And then they developed the guidelines. They had a whole series of people, virtually no funding for this, so most people did this as a volunteer process. And they developed recommendations. And I love the fact that they focused on what I focus on as a clinician all the time, which is balancing the benefits and the risks, right? You have to consider the benefit of your therapy, you have to consider the risk of your therapy, and you also have to consider the degree of uncertainty about what's going to happen if you implement that intervention. And that's where assessing the level of evidence. And then they came up with sort of pragmatic guidelines. You should do this. You know, you can do this. It's not unreasonable. You shouldn't do this. How certain can we be about that? And then they gave you a series of steps saying, you know, here's how reliable that recommendation is. And many of their recommendations ended up being consensus-driven. You know, this project wasn't magic. They didn't suddenly discover all these randomized clinical trials on all these topics that, you know, we didn't know existed. What they did was the best they could with the evidence we had. And that's what we have to do here. So then the question is, what did they do after they developed this? They didn't stop at this point. After they developed these guidelines, they developed training mechanisms. These are only useful if you get them to veterinarians. So there is, for example, an online e-learning basic life support course. They're developing an advanced cardiac life support course that you can take in your own time online for CPD credit. They're also going around and promoting this. They made this available freely on the internet and also through a number of journals in free issues of the journals, so you don't have to pay for this information. So again, they made the they looked at the evidence, they reviewed it for you, they summarized it for you, they made it accessible to you in a usable form, all the things that I think we need for this to be a pragmatic process. And now they're working at looking at whether it works. Right? Because if we're going to promote this, we need to know for ourselves, and we need to know to convince our colleagues that it actually does what we say it does. So they're establishing a registry to look at whether the implementation of these guidelines actually has an effect on outcome. And evidence-based medicine is a continuing process. It's not an ever process where you stop because the evidence develops and evolves. And so they're going to hopefully go through every 4 or 5 years, and if this is successful and popular enough, they might even get a little funding to make it easier to go ahead and review these on a regular basis. ILCOR revises the human guidelines every, I think, 5 years, and that's something that they're hoping to do. I think one of the best things that this project does is serve as a model for what we can do. This was just a group of committed people with relatively few resources but a lot of expertise and passion doing something which I think is very useful. Now, I'm on the little committee at my hospital that's implementing the Recover guidelines at our practice. We've trained all of our technicians on their roles, and the training materials are great because they talk about how to communicate with each other during a code, all sorts of things besides the medicine. And we've revised how we communicate with clients about whether or not they want to have CPR done for their pet. You know, this has stimulated a huge amount of discussion about the whole issue and how we handle things. And having implemented this, it's made my life a lot easier. There's a lot less chaos and running around and panicking whenever this happens because everybody knows their role and everybody knows there's the steps to go through. So it's been a very useful tool, and I think it can be a model of what we can accomplish, even with the resources, being as limited as they are. So what can we do? Hopefully this meeting is going to finish up talking about next steps and practical outcomes. I think as a general practitioner, what I can do and what hopefully others can do is to just begin trying to practice in this way. Accepting all the limitations and challenges that we have, start thinking in terms of clinical decision making as a process of identifying what information you need, finding that, evaluating it and implementing it and communicating with your clients, all of this. If you start doing this, then that will help you to figure out what you need to support you. And then that helps those of us who are working on developing this area generate the right tools. Talk to your colleagues. As I say, a lot of people, when I go to conferences and speak or sit in the exhibit hall, don't know that our organizations exist or don't know that there is really a movement towards doing this in veterinary practice. So, every one of you is going to be better informed than the average just by virtue of being interested in this and being here. So talk to your colleagues about it. Go through with them why this is useful and address some of those concerns they have and talk about how we do it and how it's been practical and useful for you. Obviously, we need to improve the evidence base, and as I said, a lot of this falls on the folks who are doing research in academics, but I think there are things we in practice can do as well. And partnerships between local practices and academia is a fantastic way to leverage the resources that we have to generate more evidence and the kind of evidence that will be useful to us because it's in practice, not just in referral institutions. Generating tools, the people who are in the library sciences and the information sciences can produce a lot of useful gadgets for us to make the best use of what we already have. And then those tools can make the evidence available to us and useful. And then, I find this exciting. I find this interesting. I think that it makes my life easier. It makes me feel like I'm doing a better job. And my clients, even the ones who don't always agree with me, and I generate a lot of controversy with my opinions on some subjects in veterinary medicine, but even the clients who don't necessarily like those opinions feel like I'm committed to the welfare of their animals and like I'm making a concerted effort to be informed and engaged and to learn and to accept my own limitations. And I think that enthusiasm is something that can generate more useful things. If we start with the prospect of, wow, this is really overwhelming, obviously we're not going to get very far. What resources do we have available currently? Obviously, I'm here to promote, the Evidence-Based Veterinary Medicine Association. I'd like that to be a better resource, and I'm hoping that the more people know about it, the more people get involved, the more that can be a forum for communication on the subject. The Center for Evidence-Based Veterinary Medicine at Nottingham is a fantastic group. They're all very enthusiastic and smart, and they make me feel really slow and old, and but they're doing great things, and I'm really interested in what tools are going to come out of there. And I think they need input from practitioners about what's going to be useful to generate. There's a lot of literature on this. All of the different sort of domains within veterinary practice have already, published things having to do with how do we apply this in our area. It's going to be different in production agriculture and dairy medicine than in small animal medicine. We have different information needs, we have different economic models, but there's a lot of information already out there that you can access for whatever area of practice that you're in. And I talked too fast, hopefully we left a little bit of time for questions.